exploration, primarily on the HCCN grant around health IT optimization and quality issues. I do practice on ECW, and I am working with several other health centers on ECW. By no means am I an expert, but certainly I am familiar with the platform, and any questions I don't know, I'm happy to find out for you and get back to you. So certainly any information that you may need, please write it down, and you'll have my contact information at the end of this presentation. You can always reach out to me and I'll follow up. So today's call agenda, I know it's everyone's lunch hour, and so we'll try to cover all our content. I do want it to be interactive, so please feel free to ask questions, and we will get to them throughout the presentation. So the agenda today, we're going to do some meaningful use updates, given that the deadline for attestation and registration for MU, if you haven't already, is quickly approaching. I want to touch on some care management issues with PCMH. I would love to hear from any of you around some of your UDS challenges with ECW, and that will help guide us with some priorities on future calls. And just wanted to follow up from last call if anyone had implemented SOGI or started using the prepare form for social determinants of health. So meaningful use. For those of you who don't know, May 31st is the deadline for the Medicaid Meaningful Use Program participation. So eligible providers who haven't attested for AIU or any advanced stage of MU will not be able to attest and receive incentives in following years if you don't get this done before May 31st. So for any of you who may have had some new providers out there who you can at least get on to AIU, please do not miss this opportunity because it, as you all know, that's a large pot of incentive money that can go towards the health centers. And beginning as of October 14th in 2016, MAPHERE wanted you to submit your incentive applications with the uploaded documentation that they have listed on the website that I have on the screen below. So for all of those attesting, everybody will be attesting to the modified stage 2 objectives for eligible providers. There's 10 of them. This is the list of the 10, and the next few slides, I just want to go over some of the key objectives where we can maybe provide you with some tips, and also to note where some of our providers in our health centers that we've been working with on MU have struggled a little bit. So as far as CPOE, the percentages, 60% medications, 30% labs, 30% DI. One way that you could really, that will really help support get to these numbers is setting up your staff as licensed healthcare professionals using certified MAs who are then able to execute standing orders. So thinking about as you do pre-visit planning, as you do your huddles, and you talk about orders that you anticipate you'll need for the upcoming visits on the schedule that day, that certified MAs can go ahead and put those orders in, but only if they're certified. We have been working with some health centers around standing orders for immunizations, and I'd be happy to provide you with some policies and procedures that have come through the ACIP on standing orders for immunization. Electronic prescriptions. eClinical Works automatically performs the RX eligibility for any incoming e-prescription refill request. So when a e-prescription is refilled, providers do receive credit for formulary checking, which is one of the meaningful use requirements. But as far as outgoing e-prescriptions, making sure that all RX eligibility is verified either the night before or the first same day appointments that day. for any of your e-prescribing medications going through telephone encounters, e-refill requests, etc. What I did learn, I just actually attended the ECW user day yesterday, and they have a new functionality that they think will be released by the end of the summer, which will be the GoodRx. And I don't know if any of you are familiar with the GoodRx, which is for your self-paying patients, that formulary will be loaded in the prescription module. And so the way they described it is if, for example, you have a patient who primarily uses Walgreens and you prescribe a medication, this will have a pop-up that says, you know, CVS has this medication at a lesser price. So it will be a helpful, really helpful tool for any of our self-pay patients, and given potential healthcare reforms, we're not sure if we're going to get a lot more self-pay patients if they lose some of their prescription coverage. So that is in the works to come. Stay tuned. Hopefully I'll have more to talk about specific to that on the third and fourth fall of this calendar year. So medication reconciliation, we have noticed with some of our health centers that they have struggled to meet their 50%, and it definitely is a workflow issue. And so making sure that that is reviewed with all of your providers, and particularly as you talk about who does med reconciliation, particularly with transitions of care. So for those of you who know, making sure that on the appointment box in the window chief complaint, there is a small box, and I'm sorry I don't have a screenshot of that. There is a small box that states whether this is a transition of care visit, and make sure that that is checked clearly for any ER or hospital follow-up or any return for a follow-up post specialty visit, or obviously a new patient transitioning into the practice, or a patient perhaps who hasn't been seen in 2 years, indicating the transition of care. And then just wanted to show you that there is a pop-up box that you see below to check the medication is verified box on the current medication window. So if medications are not verified during the encounter, you will get this pop-up box. So again, this is just looking at your MU numbers, looking at all of your providers. If you're finding that you're hovering around 50% or lower, walking through the workflow to make sure this is being done. ECW certainly has made it much easier to verify medications, but it's a matter of making sure that your healthcare team does it. So patient education, fortunately, it's only 10%. One of the things that I wanted to show you is a good way to get this patient education is attaching it to any order sets that you might have developed. So this is just a screenshot of one of the order sets that we have for obesity, where we have attached the patient education that we like to use, and you can see where the red arrow is here. And so when we go ahead with our order sets specific to this diagnosis, since the education is already pulled up, all we have to do is click the box, and then when we do the come and send, that will print out, and then we'll get credit for having the patient education tied to the diagnosis, the specific diagnosis. So that we have really built into any of our core order sets is we pulled in patient education that we routinely use, and it's a nice, easy way to make sure you're hitting that 10%. So I wanted to talk a little bit about health information exchange, which is always a work in progress, I think. So ECW has joined the network, which is their what they call P2P, provider to provider, and you need to request a direct address, and you can easily send referrals through the Join the Network and invite other providers to join the network through your HIS interface. And when you do that referral, you do need to attach your CCR or CCD, your medical summary, and your progress notes. And this, if you're working through your patient-centered medical home application, if you include all of these pieces, you'll make sure that you include all of the key elements and data points that are required for your transition of care and referrals. So if you are referring to non-ECW providers, they can request an ECW-issued direct address through this website. I do want to point out that you get an exclusion when less than 100 referrals are sent during the reporting period. So in my case, since I practice very part-time, this is an exclusion for me because in the 90 days I am not issuing over 100 referrals. So just know that this is a helpful claim exclusion, particularly for any of health centers who have very part-time clinical staff. And it goes without saying that printing and faxing referrals with attachments does not count towards your numerator for this measure. And again, it is only 10%. And of course, the ideal is that we work towards being able to electronically exchange information because it only sort of enables better practice, being able to have immediate access to patient data in terms of clinical decision making. So this is just a summary slide off of the ECW, my ECW portal about Join the Network. For any of those who are not all that familiar with the sort of technical piece of health information exchange, it's eClinical Works platform, and as I said, it's where you can send and receive your patient records, electronic referrals, and secure messaging. It's free, it's HIPAA compliant, and it's a considered a care coordination tool for all providers. And it does eventually eliminate your need to print or fax. And for those of you, and I'd be happy towards the end of this call to talk, to hear from any of you who have just started or have been actively using P2P to get your feedback on what your workflow is, because it is a bit of a workflow shift, and how you are addressing the workflow issues of the P2P consults that are going out or referrals going out and consults coming back in. Just again, for those of you who are not on the IT side, a HIS is your health information service provider. And again, it is sort of HIPAA compliant. It's to provide you with your direct email address and associated certificates. And that's what enables you to securely send direct messages so that your patients can be ensured that their PHI is protected and secure. So for direct messaging, to sign up for it, here's a checklist. If you haven't done so already, to register for P2P, request a direct address, and you can open up a support case for a HIS integration request, and all the documentation about how to do that is located in your myeclinicalworks.com user portal. And so you can refer back to the slide to see where you can find the P2P guide to walk you through how to register for P2P. I wanted to talk about secure messaging and how to web enable patients for the patient portal. And as you can see here, the screenshot of the patient information in the practice management side of the application, that in the options box, you see a drop-down where you will have the front desk or your registration staff web-enable the patient, making sure that this is a part of their workflow. And again, you may need to sort of review this in the same way that you need to review that you should ask for a patient email. This is what will enable you to send a secure message with any clinically relevant information. Some of our health centers, in order to meet any threshold, and now they no longer actually have a threshold, what we have done in my own practice is that any new patient, we make sure that they are web-enabled, and then after their visit, part of the workflow is we send them a secure message that says, welcome to the health center. We're happy to have you. Please let us know how your visit was. If you have any questions, here's information about how to sign up for the patient portal. So just doing any of your new patients, it's sort of a nice, in addition to handing them their your brochure about the practice that hopefully says that it's a patient-centered medical home, is that you are sending them a direct message, a secure message, welcome, reinforcing how happy you are to have them into the practice, and providing them with more information about how to securely message back as well as sign up for the portal. So it's a good workflow. It has helped us meet that objective. And our patients actually have been really happy to, have commented on, wow, when I got home, it was really nice to get this message that had, post my first visit welcoming me. So that's just a suggestion around how to implement this as part of your workflow. Again, if you web enable them at specifically any new patient, and then part of that message, secure message, is giving them information how to sign up for the portal, then hopefully we'll be able to get more people actively using the portal. And you can see here that if you also use that workflow to web enable your patients, then it should be pretty easy to meet that 50% threshold. The other thing is that I wanted to encourage you to really talk up the portal, to have signage in exam rooms, at the front desk, messaging from the entire healthcare team, MA, the provider staff, that encouraging people to try and utilize the portal. Also, really talking up the benefits of the portal. For any of you who currently use the portal for your own or your family's healthcare, you know how convenient it is to be able to log on and pull off your children's immunization records for all those sports forms and annual physicals and camp physicals, et cetera. So just really sort of talking up the portal, increasing your signage, and making it sort of part of the dialogue with the healthcare team and the patient. So moving on.
Anna, actually, if it's okay with you, I think this might be a good spot to just pause for a second. Do you think that's okay, to see if anybody has any questions about ECW and meaningful use, or perhaps if you guys have any best practices or tips that you use and are able to share around how your organization is dealing with some of the more challenging objectives that Anna discussed? If you want to raise your hand, if you want to put a question or a comment in the question box, I can unmute you. Looks like we have a couple of folks. Kim, I'm going to unmute you first, and then Manal, I'll unmute you next. Kim, go ahead.
Hi. We work in the Pittsburgh area, and there's a large healthcare system here in Pittsburgh where ECW has the ability to interface with their electronic medical record. They're actually not so interested in having to interface with us, and they're actually talking about charging us a fee. So I'm just wondering, does anyone have any strategies when we're kind of the small player in town and the big healthcare system doesn't have a lot of skin in the game to try to interact with us?
Wow. I don't. I don't know if Deb or Suzanne's on the phone, whether they've heard that from any of the other health centers in the network. But if not, what I'd be happy to do a little bit of research around how to navigate that challenge for you. So if you wouldn't mind sending me a follow-up email, and you'll have my contact at the end of this presentation. So I'll have your contact information, and I can follow up with you more directly. So essentially, they're not necessarily interested in adding your direct addresses to their network.
Well, Suzanne, actually, I'm going to let Suzanne speak. She might have some input into this. Suzanne, I've unmuted you.
Yeah, I don't have any fantastic solutions to offer. That is something that we have heard from a number of health centers on the western side of the state, that they're having a lot of trouble getting access to provider directories and setting up information exchange. And I'm sorry, which health center was the original speaker from?
I'm from East Liberty.
Okay. I'm just wondering if you guys have engaged with the state at all around this?
Yes, I have. I've even spoke to Pam, and her last name begins with a Z, from the medical. Her solution was, there is some grant money out there right now that we would be able to use that grant money to pay for this permission to get into their system.
Wow. I'm laughing because I mean, the grant money, as I understand it, because we're also it makes us realize in the Southeast that we're actually, as much as we complain about our regional health information organization sometimes, I think we're actually in a pretty good position, because the grant money is available for the health information organization, so the regional groups that that are supposed to be facilitating health information exchange. And in the Pittsburgh area, is that actually managed by UPMC?
I understand it's a subsidiary of them.
Yeah, and I assume that that is the health system that you're talking about?
That is correct, without mentioning any names.
Okay. So, yeah, so for instance, what's happening here is we're working with our local health information organization to try to get health centers onboarded to their clinical data repository, and those funds would be used to support health centers' vendor costs in order to connect to the HIE. So it just really seems problematic that that organization, which is also serving as the regional health information organization, is putting these obstacles up for non-affiliated providers. And I guess I'm wondering if there's anything that, I mean, I know the state structure is really in flux around how all of health information exchange is governed, but it just seems really problematic that you guys are being kind of held hostage by that large organization. I think it's something that, I mean, thank you for bringing it up, and I don't know that it's all that easily resolved, but I think it's something that potentially requires some advocacy, you know, at the level of not so much the operational folks, but maybe the people who are actually funding and regulating those health information organizations. So not an immediate, but
I had the same idea, and I approached DPW and with the argument that if we are all taking care of medical assistance patients, shouldn't we all have to exchange information for free because we're all trying to care for their patients?
And did you have any response?
Yeah, I have
That did not get a lot of traction.
I have a question. I have a question for you, and maybe Anna can help. This is Deb McGrath. I'm the Director of IT for the Health Federation. I'm wondering if there's any benefit here of seeing if UPMC would be interested in applying for a non-eClinical Works user direct address, so that then it would automatically be in your P2P. It wouldn't cost them anything except that they would have to do the work.
And that would be, UPMC would become a non-ECW user?
Correct. As I understand this, and please help me because I'm not an expert on eClinical, but as I'm understanding this from Anna, that there is this no-cost P2P network that eClinical Works is providing. And there is a pathway to join that network for non-eClinical Works users, which she has now on the screen. And if they would be willing to do that, then that direct address would be automatically available to you in eClinical Works. Now, I want to just say this with some reservation, because one of the things that's going to be tough is it probably won't be a network registration on the part of UPMC. They're going to have to register each one of their practices into this network in order for those direct addresses to be available to you.
Yeah, and also, Deb, there is a fee for a non-ECW.
There is a fee? Okay. Okay.
It is.
So then that probably would be a non-starter, right? Right.
It's fee-based.
Right.
So, you know.
Thanks for adding that, yeah.
You have to pay to play. So that P2P, pay to play.
Okay.
All right, so we'll move on. Anna, we did have a couple. Yeah. Deb, were you still going to go? Sorry.
No. I just, let's try to stay in touch on this issue.
I would appreciate it. We'll take it offline. Thank you.
Yeah. Mm-hmm.
Okay, Manal had their hand raised next, so I'm going to go ahead and unmute you. Go on.
Hi, my name is Jessica. I'm the clinical manager sitting here with Manal. And one of the things we're running into is the P2P and getting other providers interested in using that. And I didn't know about the fee until just now, so I'm wondering if that's part of the reason they're not interested. Does anyone know what the fee is?
I was doing a lot of research on this, and I couldn't find that information. Oh, I'm sorry, I'm getting an echo. But I can try and nail that down. You know how vendors are sort of cagey about giving you prices.
Mm-hmm. And does anyone have any strategies that they used to get the specialist offices interested in using the platform?
Boy, that's silent, really.
Sorry. I went ahead and sent out like a lot of emails and direct messages to the offices around the area, and I haven't received one response back.
This might be an interesting, it may be helpful to sort of reach out to the NAC user group, ECW user group, and see, they have monthly calls, see, what some, if anybody has sort of come up with some solutions around this barrier. So again, we're going to put this on a topic to be continued and to follow up with. And as Suzanne said, I don't think it's going to be a rapid fix, but let's keep this on our sort of ongoing agenda, and we'll try and work through getting some further information for you all.
All right, and it looks like we had one other question. Martha, who also looks like she's from East Liberty, asked, how do you suggest providing consent for portal access for children? We currently do not include patients under the age of 18 for portal data. Any suggestions?
You know, there has been a lot of, there's actually been several sort of ARC webinars around patient portal use, and actually after this call, I'm going to attend an ARC webinar on patient portal safety and access, and I'm thinking that they're going to address that as well. You know, that is particularly for pediatric practices who treat patients up to 18 or sometimes 21. They get very nervous about opening up access, but when you're talking about you know, any mental health related issues depending on your state, I think it's statewide, right? So I believe with mental health, if there's any mental health diagnosis, at the age of, I think it's age of 15, parents need consent to access any of the mental health information, as well as any family planning services. So if you've got a client coming in, a teenager who is coming in for STD testing or pregnancy, that the parent can't have access to that. So there becomes this challenge of how do you limit access to parents after a certain age, and depending on the issue, and when do you open access to a patient portal for your pediatric population. And, you know, many practices sort of at 18 open it up and say, you know, cut off a parent's access, and it goes, the 18-year-old needs to register for the portal themselves, but it becomes that tricky interim. And I would like to maybe put that on topics for future calls, because I do have some resources around this, so I'd love to put together a presentation and provide you with a more succinct list of recommendations around that.
All right, great. Anna, that looks like that is it for the questions or comments, so I guess we can move along.
Okay, so let's get back to trying to be cognizant of time. Okay, so patient-centered medical home updates, some key important dates, and is listed here. So for any of you who still need to or are planning to renew your recognition or get your recognition for the first time under the 2014 standards, these are the deadlines, and the very last day to submit under 2014 for your site is September 30th. So if you haven't begun working on it, and you were planning to do it under the 2014 guidelines, you either need to sort of hop to it and get moving, because all of your policies and procedures need to be in place for 3 months, and your chronic care management. So the deadlines are quickly approaching, and if you miss them, then you will need to, you would need to do your application under the 2017 standards, and that process will become available for review at the end of this month. So if anyone has any questions around that, but I wanted to make sure that you were aware of those deadlines. So I wanted to talk a little bit about care management and support. I don't know how many members on the call, if their practices are currently recognized as a patient-centered medical home, or if you're working on it. And the last user group call, and those slides are available, we talked a little bit about you know, goal setting and self-management support, and how to create sort of mini templates like under HPI that you can shoot in so that you are capturing those main data points in terms of sort of barriers to medication management, self-management goals. But the challenge becomes, how do you continuously update those, and how do you share that care management plan with the self-management goals with the patient if you put it in as a template. And that has been sort of a workaround, but it becomes a little challenging. How are you documenting the care team? And so I would be curious to hear how some of you have done it thus far, and if you've been struggling with it as well as some of our other health centers. I did want to mention with the V10E upgrade, and I'm not sure how many of our callers have upgraded to V10E, that they have a care management module. And that module is included with the upgrade for all F2HCs. It is not included for private practices, but it is included for F2HCs. And it really, because it's new and I am not currently my practice is not an F2HC, so I wasn't able to take screenshots. But what I would strongly suggest, if you haven't seen it, to ask for a demo, and perhaps we may even arrange for that for our next call. But it enables you to identify your care plan team, so it's particularly helpful for integrated practices so that you can have your behavioral health, your patient navigator, your nutritionist, and your medical case manager. So everybody on the care team can be identified, and they can all work with the patient. And so the patient, instead of having 3 different care plans, depending on which care team member they're working with, this becomes a centralized care plan, which is incredibly helpful and is certainly much more patient-centered because nobody's sort of working in silo with the patient on their particular issues, and then they can reinforce the care plan from the entire healthcare team. But it's customizable. It's very similar to the asthma action plan, where you have your green, yellow, and red. So it's sort of set up in a very user-friendly, low literacy way to work with your patients around their goal setting and self-management. The care management module is really helpful for risk stratification, identifying gaps in care, and it also has this great dashboard as you to keep you on track in terms of patient reminders and outstanding referrals, any kind of reports. So I wanted to make sure that you were aware of the care management module. If you haven't upgraded yet, this is what will come as part of the V10E. It will require some workflow redesign. And again, it really dovetails quite nicely into if you are working on your patient-centered medical home recognition application, as you're really trying to think about where you are capturing some of this data around care management and care coordination. This module has made it much easier to document. I also wanted to let you know, for those of you who are working on your PCMH application, that on your My eClinical Work portal, under PCMH, if you look under resources, they have a 46-minute video with some really helpful examples of workflows that support the PCMH and enable you to sort of meet some of the standards and elements. And so sometimes at portal, there's just so much in there that it's helpful. I'm hoping this is helpful for you, that I, culled through it and dug it out, because I watched it and I found it very helpful. So now you have the link below, and if you are, as I said, working on that application, this may be a very helpful resource. So before we open up to discussion, I do want to just mention when I was on the portal, I did see that they are having a health center specific summit in Boston, May 8th through the 10th. ECW, as most vendors, always promotes their big national conference, which is usually a very big expense and is not necessarily always specifically focused on health center needs. But they do have this 3-day conference specific to health centers, and the registration fee, I think it's before the mid to end of April, is only $200, which is a pretty low cost for a user conference. So this has not until I went through the portal did I actually find this. So it hasn't been well advertised. So I pulled it out just in case you hadn't seen it. So let's go back to opening up the call for if anyone had any specific UDS challenges this year specific to ECW and their reporting, or any successes that they would like to share, anything that you would like us to support you on in future calls to prep you for UDS for 2017. So I would love to open that up and, of course, open up for any other questions.
So if you had any questions or comments, just as before, please raise your hand or enter a question into the chat box, and I will unmute you. Martha, you can go ahead.
So one of the challenges that we had with the UDS reports had to do with understanding the mapping patterns from where we entered data throughout the year 2016 that would be mapped to the appropriate UDS report. We had some challenges with understanding a variety of places. SOGI, depression screening, tobacco screening. For depression screening and tobacco screening, the directions are for the first part of that measure to be able to use the SMART form. The secondary questions are in the SMART form, but the SMART form answers to the secondary questions are not mapped to the report. You have to go to 2 separate places. One is under HPI and the other one is under preventative measures. We also ran into some issues with lab reports and diagnostics. The directions in the ECW manual say that in the lab button, the received radio button is what needs to be marked, but what we learned is that it needs to be received and reviewed. And we found some other inconsistencies in the manual. I didn't know if anybody else had run into these challenges or if anybody could provide some insight and guidance with things they addressed with ECW, what they learned, what their solutions were, those kinds of things.
Anybody else on the call have any similar challenges?
Yeah, I'm not sure. It looks like Manal or Jessica also had their hand raised. I'm not sure if that was in reference to the previous speaker or if it was something else, but you guys can go ahead.
We have something else, but I can share with what we do with our UDS measures. We were having some workflow issues with our staff. So when we do our quality meetings every month, we go through each UDS measure and see where our numbers are for the month, and we do like starting January 1st, we start doing like a year-to-date report. That way we can see if our numbers are climbing or not, and we can identify what we're lacking on, and we can focus on them. I do have one support staff member that dedicates her time to scrubbing the non-compliant charts to try and figure out if it's a documentation issue or if they simply need an appointment to address that thing. I don't know if that would be helpful. One example is the depression screening. We do the PHQ2 SMART form, which is right in the progress note, and the workflow for our support staff when they're rooming the patient to check the alerts to see if they are due for their depression screening. So if they're due, which is once a year if it's negative, so they do their depression screening. If it's positive, we set the global alert for 3 months out. So we do another depression screening to make sure it doesn't turn negative then. And then if it's negative, they reset the global alert to recheck their depression screening on January 1st of the following year. That way, if they have an appointment, they're not waiting until a year later from the time they did their depression screening, because it's so hard to capture our patients. So we thought if we set the alert at the beginning of the year, we would capture them that first visit that they come in for the following year.
That's a great idea. That's a great idea. Yeah. But Martha, it sounds like you were saying that the mapping for the depression screening was a challenge because it was that they were mapping it from several different places. Did I understand you correctly?
Okay, there I am. I'm unmuted. Yes,
that's okay.
that was one of the problems that we had run into because we were using the smart form,
right, and
answering all the questions there, but all the questions are there, and the follow-up and stuff, but that's not what ECW maps to the UDS report. And so when we did our reports, our numbers were low, and when we did our chart reviews, they were very high. And so consequently, with the look of going all electronic at some point in time in the future, date unknown, we want to make sure that we can use the electronic health record to the best of its capabilities. Mm-hmm. So that was where one of the challenges was that the forms that we were using that are designed in ECW for this use are not what ECW designs. And my perspective is if they have it in more than one place, all of those places should feed into the report, but that's not how it's designed.
Right. So I'm curious if they were using the CPT code for depression screening for the mapping.
Using the what?
The CPT code for depression screening. So, on your encounter form, when you complete the visit, and if there was a depression screening, are your providers or whoever does your sort of coding including that? If you did the SMART form for depression screening, is there then a CPT code for the depression screening that's being put on the claim?
I don't know. That's a good point. But how would that map to ECW's report?
Well, I'm wondering if they're using the CPT code as a way to say, to capture whether it's been done or not.
No, what they're using for the depression screening is that you then have to go into, if it's positive,
mm-hmm.
and depending upon what you set your value for positive, you then have to go into the depression screening under treatment. You have to go to the treatment screen down at the bottom of the progress note, and you have to go into the PHQ-9, into the depression screening, into the intervention, into the notes, into the value, and then select which one it is.
Wow. That seems like the setup is not right. You know what? Let me get some information on that. That just doesn't sound like the setup's right with that.
It's a very complicated process in my way of looking at it.
Yeah. Did you reach out to support around this?
Oh, yes.
Okay.
Oh, yes.
Okay. And
that was not as successful as we had hoped it would be.
Huh. Okay. See if we can get a little more information on that for you.
Okay, I would appreciate that.
All right. Specific to at least depression, and tobacco was the same thing in terms of you were capturing that on the SMART form, and then they were asking you to capture it, that the UDS report was not pulling from the SMART form.
Correct. And so for smoking, you have to go into preventative medicine, you have to go into counseling, smoking, the notes, and then into the value for patient counseled on the dangers of tobacco use and urge to quit, and enter the date.
Wow. Because we don't do any of that, and we run into that problem. Okay. So maybe for next
So if
call,
you don't have to do any of that and your numbers are good, we'd like your process, please.
Okay. All right. Okay. So this is like, this is great because this helps us form some priorities for next fall. And okay. So not capturing data from smartphones, particularly smoking and tobacco. Anything else from any other listeners?
And it looks like that might be it on the EDS.
It looks like Manal just raised his hand.
Oh, sorry about that. Did not see that. There you go. You're unmuted.
We had a couple issues. This past year, we had our colorectal cancer screening number. As of November, it was 57% compliance, and in December, when we were ready to run our reports for reporting, it went down to 23%. And after a long time of trying to figure out what in the world happened, they used to have us document the colonoscopies under the lab results, and then when they redid the package, they decided that it was going to go under procedures. Okay. So, but nobody really communicated that to us, so we had to figure that out and go through and as much as we could go back into patients' charts and redocument. So.
So they kind of switched it halfway.
Mm-hmm. And we have another challenge with our immunization number. That one's pretty low, and we're thinking it's because of them adding in the requirement of the flu shot. We have many parents that refuse that. Or we also have patients that come to us that are already non-compliant on their rotavirus or Hib, and now it's too late to give them that, and they're just always going to be non-compliant.
Yeah,
that's just
immunizations
frustration.
Yeah, immunizations are always going to be a challenge, especially for those very time-limited ones like rotavirus that, if you don't get them in and you miss, then, you're gonna miss those numbers. That is a challenge. And just, across the board, at least in our network, we really saw health centers struggle with their immunizations, particularly with the change now from under 2 instead of less than 36 months. Okay, so this helps us as we start to think about topics for the next couple of calls. And what about the FIT test for your colorectal cancer screening as well? Same thing? Is that also considered a procedure, or does that come in as lab?
I believe that would be a lab, but I haven't specifically checked that one out because we're not doing FIT testing here yet. We're doing the fecal occult. We're doing fecal occult or manually entering the colonoscopies, sigmoidoscopies when the GI specialists send them back. The fecal occult goes under lab, so I would imagine when we start doing FIT testing that it would also go under lab.
Right, so then you've got a report that's got to make sure it's pulling both from procedures for colonoscopy, sigmoidoscopy, and lab.
Right. The problem is when they switched where you document the specific colonoscopy, sigmoidoscopy.
Yeah, that's a problem because it's not like you're documenting it every year. So that, unless you end up changing, because it's something they have, someone might have every 10 years. Yeah, that is a challenge. Okay. Let me do some sleuthing around that and see what I can find out. Okay. Any other questions? Input? we've got some priorities for next call. Okay. We also, I don't know, has anyone implemented the prepare form, the one that was released to capture social determinants of health? Is anyone familiar with that? If not, it's certainly something I can present on one of the next calls. Okay, I'm not getting any yays, so that may be something we'll put on the agenda. All right. So Holly, you're going to have all these slides on the portal?
Yep.
Okay. Well, I thank everyone. We got you in an hour during your lunch hour, so hopefully we didn't disrupt too much of your day. And I have my marching orders to come up with some resources and support for you. I appreciate your time, and it's very helpful for us to really build this group as an interactive group to support one another and share resources. So I hope we can continue to gather. Do we have our next call set yet, Holly?
We do, although we may want to reschedule it just based on having to reschedule this call. I'll send out some information. Like I said, a few housekeeping notes. I will have the recording of this call and the slide deck available on the Health Federation's HCCN project portal. We'll also be sending out a brief survey this afternoon and would appreciate your feedback on that. Perhaps I'll add a question about scheduling of the next call to make sure that this is, a good time and date for everybody. And if you have any questions around what Anna covered today, please don't hesitate to reach out to somebody on our Health Federation HCCN project team at any time. So thanks again, and enjoy the rest of your afternoon, everybody.
Thank you.